Hello, everyone. Thank you for joining for the third session in our Supported Decision-Making in Delaware speaking series. My name is Ashley Steinbrecher, and I am a researcher with the Delaware Network for Excellence in Autism, or the DNEA. The DNEA is housed at the University of Delaware's Center for Disability Studies and offers training, technical assistance, and information dissemination that benefits people with autism, their families, and the professionals who serve them. Similar to our previous two sessions, a resource guide that supplements today's topic, along with PowerPoint slides and related resources, have been compiled onto a Padlet to share with you today. Recordings from each session are also posted here for you to access. The link to this Padlet will be dropped in the chat toward the end of today's session. Today's resource guide and other topic-specific resource guides are free to download on the DNEA webpage. We will also be sharing an evaluation link into the chat at the end of today's session, and we'll be sharing this link in a post-session follow-up email to you as well. Thank you in advance for taking the time to complete this evaluation. And at this time, we are very excited to welcome back our esteemed guest speaker for this series, Jonathan Martinis. Jonathan is an attorney and the Senior Director for Law and Policy for the Burton Blatt Institute at Syracuse University, with over 20 years of experience representing and advocating for people with disabilities. Jonathan plans to incorporate enough time throughout his presentation for some questions, so please feel free to add any questions you may have to the Q&A. Thank you for being with us today, and Jonathan, I will turn it over to you.
Thank you so much, Ashley, and thank you so much, everyone, for joining us for the third in our series on supported decision-making. Like our last presentation, this is a how presentation, how you can incorporate supported decision-making into supports and services, into activities, into the life course that people with disabilities follow every day. So this is about ways that we can incorporate supported decision-making into healthcare supports and services, financial management supports and services, and other areas around people's lives. So let's begin by me sharing my screen. And as always, what we're going to start with is what I call an article of faith. How we always begin with what the overarching theme is for this presentation, and that's this. This comes directly from the Americans with Disabilities Act. Just because one has a disability, a physical or mental disability, does not in any way change their right to be a full participant in all aspects of society. In other words, this law in 1990, so 224 years almost, 114 years, pardon me, I'm bad at math, after the Declaration of Independence said that all people were created equal, we finally got around to saying that people with disabilities are people, that people with disabilities have equal rights, that people with disabilities should have the right to life, liberty, and the pursuit of happiness. That is our theme for today. Things that will ensure that people with disabilities have an equal chance to do the same things everyone else does every day. And how do we get there? Well, what we know is that self-determination is the key to that good life for people with disabilities. We know 40 plus years of studies saying that when people with disabilities have more self-determination, when they make more choices, they have a better quality of life. They are more likely to work. They are more likely to live independently. They are more likely to be parts of their community. And we also know from our prior presentations that supported decision-making is a way to get to self-determination, a way to empower people to make the decisions they need to make in their lives, to do the things they need to do so they can be the causal agent, the driving force, the one who makes the decisions. Why? Because we know that when people with disabilities make more decisions, when they have more control over their lives, they have more self-determination. And when they have more self-determination, they have a better life. So what we need to remember about supported decision-making is it is the same thing we all do to make decisions. It is the same thing you and I and everyone else does every time an important decision has to be made. When we ask a friend for advice, when we ask a coworker about a situation on the job we've never faced before, when we ask the doctor not to speak jargon and to talk to us like regular people. Whenever we do that, what we're doing is we're getting the information and advice we need to understand the situations before us, to figure out what our options are, and then to choose the option that is best for us. And like I always say, supported decision-making is so ingrained in our society as something you're supposed to do. There's even cliches about it. Make an informed choice, don't make a snap judgment, get a second opinion, don't go off half-cocked. All of these mean the same things. Think your decisions through, get the help you need, and make the best decision for you. Because, as I said, research shows that benefits people. Like I've shown you, our study in Virginia showed that young adults with intellectual and developmental disabilities who were empowered to use supported decision-making showed improvements in their qualities of life. We're more independent, we're more confident, we're better at making decisions, and made objectively better decisions. So that's our introduction on what and why supported decision-making is. And that's why it has become so popular. In the 10 years, just 10 years, since I represented a young woman named Jenny Hatch in the first trial to hold that people have the right to use supported decision-making, 23 states, and we are hopeful that North Carolina will be the 24th very soon, and the District of Columbia have endorsed supported decision-making by passing laws or changing their laws to recognize it. State and local and federal government entities have endorsed and recommended supported decision-making. Interest groups like the American Bar Association, the National Guardianship Association, the Autistic Self-Advocacy Network, the ARC, the National Alliance on Mental Illness, have all taken positions in favor of supported decision-making. Why? Because it's directly related to self-determination, and that is directly related to quality of life. But there is a problem, as there always is a problem. The problem is cultural. As we have discussed, the idea that people with disabilities aren't able to do the things has followed us for millennia, and we see it in healthcare. Healthcare is such an important part of our lives, being able to manage our healthcare, being able to speak with our doctors. And yet healthcare is one of the areas where people with disabilities have the worst opportunities, the least opportunities, the worst supports. We know from the US Surgeon General that people with disabilities have more medical needs but get worse diagnoses, get worse treatment. We know that people under the use of guardianship, which can take away the right to make medical decisions, has tripled in just the last generation, since 1995. And we know from a study that many people say the first person who recommended guardianship to them was a medical professional. So we see in the medical field a push toward removing self-determination with good intentions, of course. But what I hear from doctors time and again is that they need to make sure that their patient can exercise what they call informed consent. That if you cannot do informed consent, you're going to need a guardian. They can't treat you unless you can provide informed consent to the treatment, or there is someone who can provide informed consent for you. It always makes me wonder, and I always ask them, really, what is informed consent? Is informed consent understanding each and every word on the pill bottle, knowing what the pill is made of, or knowing each and every step in surgery? No, of course not. It can't be. Because if that was the standard, we'd all need guardians. Because there are those of us, I am one of them, who simply trust their doctors. When the doctor writes a prescription, I take it. I have no idea why the doctor prescribed that particular medication. I'm not reading all the tiny words on the label. The doctor says, you have this condition, take this pill. I am taking that pill. I'm doing it because I trust my doctor, because I got information from that doctor, because that doctor listened to me and made a consideration of what I needed. In other words, that doctor used supported decision-making. So when doctors say we have to ensure informed consent, I ask what that means to them. What is informed consent? Because again, it can't be knowing everything about your care, because then I would need a guardian. So the American Medical Association broke down informed consent into 3 steps that really make sense and they're easy. For informed consent to happen, I have to tell the doctor how I feel. I have to report my symptoms, report my situation. Then 3 things have to happen. The doctor has to understand it and give me his or her recommendation. This is what I want you to do. This is what you should do. This is the medication I'm prescribing. This is the treatment or therapy I'm recommending. I have to understand that. I have to be able to understand what the doctor is recommending and why the doctor is recommending it. And then I have to decide whether or not to do that and communicate that back to the doctor. Say, you know what, that sounds like the right course of action. Or you know what, that doesn't sound like the right course of action. I'm going to do this or I'm not going to do it. And that is where supported decision-making comes into play, because all of these steps can be done through support. Just understanding what the doctor is saying, explain that to me in English. I mean, we've had that comment, and that's kind of an offensive statement, saying explain it in English, but it's that simplistic. Can I have it in plain language? Can I have it in, explain it to me like I'm a 5-year-old, explain it to me like I don't understand. All the cliches come into play. And when you say that, what you're saying is support me. What you're saying is I don't understand, because that informed consent, it's not a yes or no question. Consent to treatment is not something you have the ability to do or not do. It's dependent upon the help you have. As I always say, unless you're a doctor, or unless you're a medical professional, you cannot manage your own health by yourself, because you can't prescribe yourself medication. You can't diagnose yourself. So it can't be you have to know everything. It has to be that my understanding, my consent is dependent upon the help I have from my doctor or from anyone else to help me understand. So when I say that, when I say, help me out, when I say, I need someone to help me understand, what I'm saying is what the American Medical Association says, is that we need a way to make informed consent happen that is flexible for the person, that is accessible, the person can understand, that is immediate, so we can do it on the spot, that will improve doctor-patient communication, because we know that when doctors communicate better with patients, there are better outcomes for the patient, and the doctors enjoy their work more and are less likely to burn out. And we need to make sure that family and friends and people who know the patient can be involved if they want to be involved and the person wants them involved. Because those are the people who might normally think that that person can't make decisions and might need a guardian. So these are the things that are needed to make informed consent happen. Something that's ready, something that's useful, something that improves communication and collaboration, and something that involves people in the person's life. Well, that's supported decision-making, isn't it? That is working with friends and family members to help us understand the situations and choices we face. As the Administration for Community Living, which is an agency in the Department of Health and Human Services in DC, says, the solutions are different for everyone. Everyone needs a little bit different types of support. And in the medical realm, that's possibly more important than anywhere else, is that every patient comes to their treatment with different expectations, with different experiences. Supported decision-making for that patient is going to look different than it does for someone else, say me. I might just want to bring someone in with me to reassure me, to hold my hand and make sure I'm paying attention. Someone else might need someone to go in with them and explain things to me. Others may need to explain things to the doctor from me, give their point of view as well as my feelings. The approaches and the solutions are different for everyone. So if you are supporting someone to use supported decision-making, remember that one size does not fit all. Find that person's supported decision-making language, how he or she wants to be supported, what they want to do and how they do it. Because if we do that, then supported decision-making works in the healthcare arena. Think about what it does in all of those steps that the American Medical Association identified. Think how it can fit. People who wouldn't otherwise be able to give informed consent, people who the doctors would refuse to treat. Now, when they work with someone to help them understand and help them communicate, they can get treatment and they can make those medical decisions. And by the way, there are studies showing that can happen. Doctors who might have bad communication with a patient, who might not be able to make the patient understand, or who might think the patient can understand, or who would recommend guardianship before they treat, will now be able to work directly with the patient and the patient's supporters, have better communication, better collaboration, which we know leads to better outcomes. And finally, those family members and those friends and those professionals and those people in my life now have a role that I give them. A role that I recognize. They're part of my healthcare, and where they might look at me previously and say, Jonathan needs a guardian. Now they're saying, Jonathan can do this because he has my help. Jonathan's on top of this because he has our help. That leads to better relationships and better outcomes for the person in the social realm. So what do we do? This is another thing I hear from doctors a lot. I get doctors saying, we can't treat people who can't give informed consent. And by the way, that's true. If someone truly can't give informed consent, doctors can't treat. The question is, how do we empower informed consent? The second thing I always hear from doctors is they cannot use supported decision-making because supported decision-making requires a supporter in the room. And they'll say, we can't have a supporter in the room. We can't have a third party there because of HIPAA, because of the law called HIPAA. HIPAA stands for the Health Insurance Portability and Accountability Act. If you've heard of HIPAA, what you know it says is that doctors cannot share a person's healthcare records, that a person's healthcare records and information are confidential and belong to the person. So a doctor can't just give material to a third party. And you know what? The doctors are right. They are right. They can't just give. They can't just let a third party in the room. They can't just let someone be there and get information and medical records about me. But what that really means is they can't do it without my permission, because under HIPAA, the right to privacy belongs to me as the patient. The doctor cannot share my information because it's mine. However, I can give the doctor permission to share my information with anyone, including my supporter. That's the thing about HIPAA that I think doctors sometimes don't understand. It doesn't belong to them, it belongs to the patient. If I have the right to privacy, I can share that right. I can waive that right. I can say, with regard to my father, my mother, my brother, whoever is there with me, I want you to share the information with that person with my permission. So when doctors say, and they may say it to you, we can't use supported decision-making because of HIPAA, what they really mean is that we can't share the patient's information because of HIPAA unless we get the patient's permission. So give permission, because supported decision-making is all about sharing information with permission. Think about it. I am sharing information with the doctor about how I feel. And the supporter I bring is helping me do that by keeping me on track, or talking to me, or talking to the doctor about what I'm saying. The doctor has to share information with me, what the doctor thinks is going on, what the doctor thinks I should do, what medicines or courses of action the doctor thinks I should take. And my supporter can help with that too, by giving me information, helping translate into plain language what the doctor is saying to me. So that if it's jargon, that person can work to take that jargon and put it into plain language where I can understand it. I then have to decide what to do. And my supporter can help me do that in the same way that supporters help us make decisions all the time. I can talk it out. I can make a pro and con list. I can go through ideas, all with my supporters, so long as I've given that permission. And finally, I can communicate my decision to the doctor with help from the supporter if that's what I want. So in all of the critical steps that the AMA identifies, what we know is that support can touch all of them, because that person I choose to support me can help me understand what communicate with the doctor, understand what the doctor is saying, make a decision, and communicate that decision. So that's how we can make it happen. That's why we should make it happen. What do we do to make it happen? So when doctors say to me, I can't do this because of HIPAA, and again, I've heard it many times. The answer is, of course, yes, you can, as long as someone gives you permission. And here's why I know that's true. Because every time I go to the doctor, every time you go to the doctor, you have to sign a notice. Usually it's called Notice of Privacy Policies, or HIPAA policy, or privacy information, where what it says over this long page, if you read the tiny words, it basically says, we as the doctor cannot share your medical information. We will not share your medical information. And then near the bottom, it says, I give you permission to share my medical information with this person. I can handwrite in someone. Well, if I'm giving you permission to share my medical information with a third party, why can't I do that to share medical information with my supporters? They're a third party after all. I can write on the form where it says, I give you permission to share information with this person, write the person's name, and write something like it's on your screen. I authorize you to share information to help me make medical decisions. And I authorize this person to attend my medical appointments. You then sign it, you date it, and you say, put it in the front of my file, so that you always have it on file, that I will be bringing a supporter with me to this meeting. There are other model forms you can use. Now, the good news is in Delaware, you already have a supported decision-making form. You have one that is legally binding. I, of course, always say use the one in the law if you possibly can. We talked about that in the very first presentation. But if you're looking for model medical supported decision-making, if what's on your screen seems too simple, there are others at the National Resource Center for Supported Decision-Making, supporteddecisionmaking.org. There is a library that includes a library of forms. We can make it even more complex if we want. We can write an authorization that gives permission using HIPAA. If HIPAA is going to be used against us, we should use HIPAA in a way where we tell people HIPAA applies and I'm waiving those rights. Feel free to take my language. I authorize this person to work with me to help me understand, and I intend for that person to be treated as my agent for purposes of HIPAA. Citing HIPAA, citing the law in HIPAA, and any other federal law that might protect my records. In other words, I know that I have rights under this federal law. I know that one of those rights is you're not going to share my information. You can't share my information. I'm giving you permission to share my information with this person for this purpose. And we can go even farther into ways that can help us in other areas of life. I'm a huge fan of powers of attorney. What a power of attorney does is it says, God forbid something happens to me, I want Ashley to make decisions for me because I can't do it anymore. But we can write in supported decision-making into those types of powers of attorney. We can say, God forbid something happens to me, Ashley, I'm empowering you to make decisions for me. But look at the bold words at the bottom of the page. I'm giving you that power to make decisions, but you agree to talk to me first. You are going to find out what I want, and you're going to give primary consideration to what I want when you make those decisions. In other words, you get to make the final call, but if you're not talking to me and getting my opinion on it, and at least listening to my opinion, you're not doing what you're supposed to do. We can even go more detailed than that. What you're looking at on the screen is part of a medical advance directive that I wrote. After a person was injured and went into a coma, and her mother became her guardian. I think I told this story in the first session. When Tanya, her name was, began to regain her abilities, she and her mom began to argue back and forth about how much authority she should be given, about how much power Tanya should get back. And they were fighting back and forth. And I was called in by a judge to mediate between them. And what I rapidly learned was, number one, they both wanted the same thing. Tanya wanted to make her own decisions, but wanted mom's help. Mom wanted to be there to help Tanya when she needed help. In other words, they both wanted to work together. So we made an advance directive about healthcare, and we got very detailed. We identified specific decisions that Tanya did and didn't want made. And we wrote this advance directives that essentially said, if you get power, mom, you don't have power now, but if two doctors say that I cannot make decisions, that I am incapacitated, even if I use supported decision-making, then and only then do you have the power to make decisions. But here are some decisions you're never allowed to make. You're never allowed to agree for me to get shock therapy. You're never allowed to agree for me to get certain psychotropic medications. You always must advocate for me. And other stuff you'll see in the bold. If it's not one of the decisions we laid out, then mom has to talk to Tanya and get Tanya's point of view and do what Tanya says, unless it's clear that Tanya isn't able to communicate. And if that's the case, then mom is charged to make the decision, but it has to be, in mom's opinion, the decision Tanya would have made, even if that's not the decision the mother would have made. So that became a legal document that enforced supported decision-making, because the mother had to work with the daughter. The mother, even if the mother was the guardian, even if the mother had power, supported decision-making was how they were going to make it work. And we put that in to the point where it was legally recognizable. We can do it in other ways too. Because what about times when I want help, but I'm still able to make decisions? I don't need someone to help me and become my decision maker. We can put that in an advance directive. Because remember, like a power of attorney, advance directives say, God forbid something happens to me, I want this person I've chosen to make decisions for me. And that's fine as far as it goes. But what about when that person doesn't have the power to make decisions for me and I want help? I can put in my advance directive, you, Ashley, are going to have authority to make decisions for me if I am incapacitated. But even when I'm not incapacitated, when I am the decision maker, I want you to come to the doctor with me. I want you to come and help the doctor understand me and me understand the doctor, and I want you to support me so I'm able to make the decision in a way that ensures I understood it. And just like that, you are creating legally enforceable, set forth in an advance directive, supported decision-making in the healthcare realm. You can bring that power of attorney to your doctor and say, here's a copy. This is why I'm going to have this person in the room with me. Now, think about the supports and services that involve healthcare. There are many, and many are funded by the federal government, and lots of people take part in one called Medicaid waivers or other supports that involve what we call person-centered planning. What person-centered planning is on your screen. I pulled this directly from Medicaid's website. What it says is this: when you have a person-centered plan for a Medicaid waiver, for a Medicaid plan, for a plan for achieving self-sufficiency from a Center for Independent Living, whatever plan you have is designed to reflect my preferences and goals. If it's my plan, it should reflect what I want. And it should cover a whole bunch of life areas like you see on the screen, things like community participation, employment, education, wellness, etc. And all of those are supposed to be in a plan, and all of those are supposed to have goals and supports attached to them that reflect what I want, the decisions I want to make. So if you think about person-centered planning, what I always take away from the person-centered planning trainings was the whole point of person-centered planning was for my counselor to understand by talking to me what's important to me, what I want, what's important for me, what I want to do, what is important to me and how I want to do it, what my strengths are, what my interests are, the things I focus on, the things that are important to me, my values, who I want in my life and how I want them in my life, where I am now and where I want to go, what I want to be in my future, where I see myself in the future so that I can set up the supports and services I need to get there. The whole point is you take the time, counselor, to understand who I am and what I want, to understand what my goals are in areas like community participation, employment, healthcare and wellness, income, etc. That's what that's all about, taking the time, because if you do that, then the counselor is in the position to give me advice. Well, based upon what you're saying, it sounds like this is what you want to do. Is that right? And if that's what you want to do, here are some things that we have that can help you get there. So my counselor bases his or her recommendations for my supports and services on my strengths and interests, and then recommends things that he or she thinks I might like to give me the option to choose them if that's what I want. In other words, the counselor provides information and advice. The counselor informs, the counselor advises so that I can understand and decide. That's supported decision-making, isn't it? It's supported decision-making the same way the student-led IEP in special education is, as we talked about in the last session. The same way informed choice in the vocational rehabilitation process is. The same way those powers of attorney language and those advanced directive language that we just saw creates supported decision-making opportunities. And where are some other places we can make that happen? One that I think is incredibly important for people to know about, and not as many do as should, are centers for independent living. A Center for Independent Living is federally funded, and what it's supposed to do is provide supports and services that help people, well, live independently. By that, they mean be parts of their community, avoid institutionalization, and have opportunities to do the things that we all think are important in our lives. Rhode Island has Centers for Independent Living, 2 major ones. You can find out more about the CILs, as we call them, and the supports available at them by going to the website on your screen. The State Independent Living Council, is that what it stands for? The SILC, if you will, is designed to bring together supports and services at the CILs, designed to help the CILs navigate their way forward as they help people with disabilities become more and more independent. And the way CILs do that is providing individualized services. They are specifically authorized, required actually, to provide people supports and services in independent living, to help counsel them on what they need and might want. And that counseling can be peer counseling from a person with disabilities. It can be psychological counseling from a professional. They can provide housing information and services, and other meaning anything else a person might need to live and function independently. That means that supported decision-making can and should be part of SIL practice. You can go to a SIL and ask about it. And the beautiful part about a SIL is that by federal law, the majority of SIL employees must be themselves person with disabilities. So you can be learning supported decision-making from people who learn to use it themselves. So from peer to peer, this is what I did, something you might want to try. This is the things that worked for me. You might consider that. These are the dangers that I saw. Be aware of them. We can have people with disabilities serving as leaders, serving as mentors, so that people with disabilities moving forward have the options, have the supports, have the services they need to live their best possible life. Another area where supported decision-making can be incredibly important is in Medicaid. And if you are a parent and your child is on Medicaid, or if you're a teacher or a counselor and you are supporting a child who is on Medicaid, you need to know 5 letters, EPSDT. These are the 5 most important letters for young adults and children with disabilities who are on Medicaid. And it stands for Early and Periodic Screening, Diagnosis, and Treatment. Quick background on EPSDT. Its entire purpose is to help identify problems when people are young, so that they don't become chronic problems as they get older. And that's the whole point of EPSDT. Find potential problems, figure out what will make them better, and put into place the things that will fix those problems, help them, or at least keep them from getting worse. What to know about EPSDT is that anyone receiving Medicaid, anyone receiving it who is under 21, is already receiving EPSDT. You do not have to apply for it. It is not a separate thing you have to go for. EPSDT just means Medicaid services for people under 21. You don't have to enroll. You don't have to move. You don't have to move to fill out an application for EPSDT. It is supposed to already be there. However you access Medicaid, whether through a waiver, whether through the main state plan, whether through an HMO, if you're getting Medicaid, you're getting EPSDT. And that's important because here's, again, quick background on Medicaid. In Medicaid, states receive money from the federal government, and they receive some money, and there are things they must do for that money. Every state participating in the Medicaid program, and every state does, must do certain things, the minimum things they must do. I always look at it like a menu, like that's column A. They get specific money and must do the column A activities. They don't have a choice. If they're in Medicaid, they've got to do column A, things like maternal and child health, things like medical and mental health care. However, under Medicaid, they also get the option of doing other things. And if they choose to take that option, the federal government will give them more money, but they don't have to. They can participate in Medicaid without doing anything from column B. That's what you need to know. Every state must do column A and can, if they want, do column B. They don't have to do column B unless it's a child receiving services under EPSDT. If someone is receiving services under EPSDT, meaning anyone under 21 getting Medicaid, the state must cover everything in column A and everything in column B, even if they don't provide the column B stuff for anyone else. So what I'm saying is, think of it this way. Delaware participates in Medicaid. There are things Medicaid has chosen to do and things they have chosen not to do. If a child receiving Medicaid needs a support or service and Delaware doesn't provide it, but some other state does do it, then Delaware has to do it for that child. That's how EPSDT works. For kids 21 and under, anyone, anything, any service, any support, any therapy, so long as it is coverable or has been covered somewhere, must be covered in Delaware. The practical example is, I live in Virginia, so I always use Virginia as an example. In Virginia, until very recently, Even though the state had the option to cover dental services, it didn't. So if you were under Medicaid, the only dental service that was covered was tooth extractions. I had seen institutions full of people with intellectual and developmental disabilities with no teeth, because that was the only option. Otherwise, they had to rent out. There's no dental care. And by the time they had rotted out, they could pull them. Well, the difference was for kids, Virginia had no choice. They couldn't say, we don't cover dental care for people on Medicaid, because they had to, because other states covered it. Other states covered dental care. And if other states could cover it, Virginia was required to cover it under EPSDT. Now, that is important because what it means is this. If you're working with a child, your child, a student, a patient, a person you're working with, and that child is having difficulty making decisions or having difficulty advocating for him or herself, or is having difficulty putting together the steps they need to take charge in their lives, then any therapy or support or equipment that could help do that would be covered by Medicaid. I had a client I work with who was on a self-directed waiver. That meant that that person was required to hire and fire and supervise his staff. What we argued was he didn't have the self-determination skills, the organization to do that. He needed a computer. Computers were not covered under Medicaid, but other states did cover it. And because, as his doctor said, that computer was integral to that young man being able to hire, fire, manage his staff, approve timesheets, etc., the computer was necessary to help address the deficits in self-determination. We got that covered. So if there are disabilities that are impacting a person's ability to take care of themselves, as we learned is the primary driving reason for guardianship, society thinks this person cannot take care of him or herself. If there's something there that would help that, if there's a support, a service, a therapy, a piece of equipment, then it should be coverable under EPSDT. It should be coverable for a kid, even if the service you're asking for isn't covered by Delaware's Medicaid. And that's particularly important for students. Students in special education who receive Medicaid have the potential to get all kinds of supports and services. I'm sure people listening to me understand what I'm about to say. I have been to tons of IEP meetings where schools have refused to provide certain supports or services. And they'll say during the meeting that we're not providing that because the things you want it for aren't things we see in the school or aren't related to their education. Then they'll come up to you after the meeting and say, we know your child needs this, but we can't afford it. Or if we did it for your child, we'd have to do it for everyone. We don't have the money. Well, here's what I've told schools across the country. If a school becomes a Medicaid provider, generally a paperwork exercise, meaning I have signed up to bill Medicaid, anything in the IEP of a student who receives Medicaid, so a student in special education who also gets Medicaid, anything in that IEP that is medical is covered by Medicaid dollars. So the school doesn't have to worry about going broke. So if there's something in a related service about a therapy, about a medical support, about specific supports and services designed to raise my self-determination, as long as we can properly characterize it as medical in nature, then Medicaid will cover it if, one, the student is receiving Medicaid, and two, the school agrees to become a Medicaid provider. It is a great way to get around the whole we can't afford to provide this conundrum. I've told this to schools, and schools have raced to become Medicaid providers. But it's not just healthcare that supported decision-making can help people make decisions in. Consider the other areas of people's lives. The number one area after safety is always the number one thing I hear why someone needs a guardian. But number two is about finances. I have to have a guardian so my child doesn't waste money. My child isn't swindled. So there's control over a budget. Well, supported decision-making can help with that too. And the first place I want to talk about where supported decision-making can help is vocational rehabilitation. We talked about VR last time, but VR can help with finances. Remember that VR can provide anything that a person needs to help him or her work, to get ready to work, to get a job, keep a job, advance a job, get a job back. In Delaware, VR, vocational rehabilitation, is known as the Division of Vocational Rehabilitation, or DVR. On your screen is a link where you can apply for services for VR. I always recommend that every person with disabilities should apply for VR because it's an opportunity to get supports and services and work. So I highly recommend that. The thing that stops people sometimes from applying is that they're afraid of earning money. Because if you do receive benefits like Medicaid, like SSI or SSDI, you have been told you cannot have money. You can't have more than $2,000 to your name. And if you have more than $2,000 to your name, you're going to lose the benefits you depend on for your health, for your finances, for your opportunities to live in the community. So people are legitimately afraid to earn money. I've heard it called the fiscal cliff, that if you have more than 2,000, you go over the fiscal cliff and you lose your benefits. So as a result, people are legitimately afraid to work. That's where VR can help you, because VR not only can provide you with the supports and services you need to learn how to work, to get the supports you need, to get the education you need, to have the transportation and healthcare you need, it can also help with your benefits. A recognized VR service is called benefits counseling. The job of benefits counseling is to help me manage my benefits, to make sure I don't go over, to make sure I report properly, to budget, to keep track of my assets. They can refer you to counselors known as Community Work Incentive Coordinators, or CWICs. The whole job of the CWIC is to help me make sure I'm not going over the fiscal cliff, and to help me find ways to earn more money while keeping my benefits. So do not be afraid to work if you have benefits. If you're getting SSDI, SSI, Medicaid, Medicare, food stamps, you can still work because VR can help you manage how much you make and maximize what you make through benefits counseling. But we can also do it in other ways. Finances isn't just about working, it's about spending money too. Like I said, the number one reason I hear for guardianship is my kid can't manage money. My kid will get swindled. I have to have control for safety purposes. And what you're looking at on your screen is a language from a power of attorney I did after a parent told me that. The parent said that their child was having trouble with money, could be swindled. And the kid said, yeah, you know what? I could be swindled. I don't want to get ripped off. What we did was we created a power of attorney that said that that kid was on an allowance. Basically, you get this much dollars per week. And with that money, go nuts, make decisions, make good ones, make bad ones, learn what it means to make fiscal decisions. But anything over that amount, you can't do without mom's sign off. That is easy to do today. Preset debit cards or preset credit cards are easy to set up so that you can't spend more than what's on the card. So I can put $50 on the card and go, that's your money for the week, do what you need to do. But look at the bottom of the screen. We also said, if the kid wanted to spend more than that, wanted to buy a car, he couldn't do it without mom's okay. Mom had to sign off. But look at the bold words. What we said was, before mom said yes or no, they had to have a conversation. Mom had to listen and give primary consideration to the kid's rationale for why he or she wanted to spend that money. In other words, mom might say, yes, you're right. This is a great deal for a car, or might say, no, it's not time for you to have a car, but it's also a chance to have a conversation in that situation about budgeting, about working, about setting money aside, about what goes into the financial decision of making a car. So it's not just a yes or no question. It's an opportunity for education, an opportunity to work together, an opportunity to grow together. And we did the same thing for banking. We said, you can withdraw this much amount. You can write this much on a check. Back in the days when people actually wrote checks. But we also said, if you want to withdraw than that, if you want to write a check for more than that, the check had to be signed by two people. Mom had to sign off. But just like before mom said yes or no, they had to have that conversation. They had to talk about it because the kid might have been right. He also might be wrong. And if he's wrong, it's a chance for education, to talk to that kid about the best ways to get to where he or she wants to be. That's what supported decision-making is, isn't it? It's, I am giving information to the person I support to help that person learn. put into practice the self-determination we all have, be able to exercise self-determination effectively and safely. And money is so often the last frontier. It is so often the thing that gets in the way of people with disabilities being more independent. I mean, we started today with an article of faith saying people with disabilities have a full and equal right to be parts of their community. Well, when I say part of the community, what do you hear? It can't just be live in the community, because if all you can do is live in a group home and not ever get out and not ever do anything and not ever have any money to spend, what's the point? It's the same thing as being an institution. If I have an apartment, but I'm not able to buy anything for it, what's the point? I'm not part of my community. So community integration really is how you live. It's not just where you live. It's how you live. It's participating in the community, including in the financial world, buying, selling, saving, those things that get us out there doing things. I mean, think about it. Where are we most apt to meet our neighbors or meet our friends? In the workplace and out and about in the grocery store. That's where we meet people. That's where we find out what's going on so that we're out and about. The problem is that people with disabilities can't do this. They can't be part of the financial sphere. They can't be living an expansive life, buying, selling, spending money when all they can have is $2,000. If you receive benefits, you are stuck with $2,000 as your maximum. I've heard it called a life sentence of poverty because of the fear of the fiscal cliff. If you have more than $2,000 to your name, you can lose your benefits. So people don't want to do that. They can't save money until a new law was passed not that long ago called ABLE. ABLE stands for Achieving a Better Life Experience. And that's the point of the ABLE Act, to empower people with disabilities who would be subject to the fiscal cliff, who would be afraid to have money, to give them a way to have money so they can have a life. Some of you may have heard about a 529 account, an account where you can put money away for a child or a family member's education, and it grows tax-free. And when it comes time for that person to go to college or go to technical school or pay for education, you could take the money out tax-free and the person could use it. An ABLE account is just like that. It's a 529 for life. And here are the rules. If I have an ABLE account, can put up to $15,000 into it every year. Either I can put it in or someone can put it in for me. It could be gifts. So up to 15,000 does not count against the 2,000 for the fiscal cliff. We can put 15K in there and it grows tax-free. And I can take that money out at any time with no penalties and no impact on my benefits, as long as I'm using it to provide for my life. And I will talk about what you can use it for in a second. Things to know, though, is that no matter how much you have in your ABLE account, it does not affect your benefits as long as it is less than $102,000. Once you have $102,000, SSI or SSDI will be suspended, but you'll still get Medicaid. So it's not hard to spend down below $102,000. Point being, this is a chance for people to have money and earn money and save money and use that money the same way everyone else does. Almost every state has their own ABLE account. You can look at Delaware's at the link on your screen. You can learn more about ABLE accounts at a group called the National Resource Center on ABLE, or ablenrc.org. When you go to ABLE NRC, you can learn about your state's programs. You can learn about your options. You can learn how to open an account. And that's the important part. All you need to be able to do to open an ABLE account is be receiving benefits. You're either getting SSI or SSDI or Medicaid, or you would get it if you applied. So people who aren't getting SSI or SSDI, if they get a letter from their doctor that says, Jonathan would qualify, you can still open an ABLE account. Why would you want something like that? Well, my niece has an ABLE account, even though she's not receiving SSI yet, because she has an autism spectrum disorder. And my brother thinks she can live independently, but just in case she's going to need benefits one day, he opened up an ABLE account as early as possible so it could grow for her, so that should she need it, it will be there. So that's it. As long as you would have been found eligible, you can get an ABLE account. What can we use an ABLE account for? The things on your screen. On your screen are lots and lots of words in tiny letters. The reason the letters and the words are so small are because there are so many things you can use ABLE for. There's almost nothing you can't use it for, including things like vacations and clothing, things that people with disabilities need to do like everyone else does. But you can use it for education expenses, tuition, anything like that, housing expenses, rent, a mortgage, home improvement, employment training, employment support, transportation, taking the bus, buying a car, health care, premiums for health insurance, equipment, glasses, all these things you can use an ABLE account for. And what's amazing about an ABLE account is for some people, it's a pathway out. Remember, I said that benefits are a life sentence of poverty. Well, for some people, it can be a pathway out of that. I'll tell you a story about a young woman I worked with in Indiana. She was afraid to work because she was on benefits. So she never thought to work. She opened an ABLE account up and got a low-paying job, minimum wage job at a hospital. But that allowed her to earn money and save it. And she took some of that money out and she got more employment training, which led to her getting a better job, which let her make more money, which let her take some more out and pay for things like a better apartment or pay for things like more education and training and get a better job. And essentially what she did was she kept using the money she earned and ABLE funds to help her advance in her career. The last I heard, Jamie had a full-time job with benefits. She had done so well, she worked herself off the need for SSI and SSDI. Will that happen for everyone? Of course not. But it is worth exploring because people with disabilities deserve to have an opportunity to do the same things as everyone else. An ABLE account, if you're on benefits, can help you have the money you need, as I say it very simply, to have a life. We all want that kind of life. And the beauty of it is that ABLE accounts, whoever holds the account, if it's my account, I am the one who has to decide how the money is invested, how it's spent, how much I put in, how much I take out. I am responsible for managing the account because the point of ABLE is to support people with disabilities to be more independent, to be more self-determined. Well, if the point is self-determination, shouldn't we be using supported decision-making to manage those accounts? In fact, it's a perfect opportunity. Parents, if your child is on benefits or suspect he or she may wind up there, you can open an ABLE account for them and help them manage it. The child's job is to manage the account. The adult's job is to manage the account, but the adult can use supported decision-making to do so. In fact, most ABLE applications let you say right up front, I want this person to have access to my account to put money in, or I can say to take money out. I can define what their level is. But since I have to make the decision about how to use the money, then I can identify people to help me make it. That's how ABLE can not only support you to have a life through money and opportunities, it can give you the practice in making decisions that you need to plan for and make the decisions in that life. And it doesn't stop there. I've shown you, I hope, through these courses that the whole point, supported decision-making, can trace people's lifespan. Well, people's lives change over time. So every power of attorney I have, every plan I have, has what I call a growth clause. It's on your screen right now. It says once a year, we are going to take a deep dive into this plan, into this power of attorney, into this advanced directive to see if it's still appropriate. Remember the money issue where we said you can spend up to $50 a week? Well, we can say if the kid is getting better at managing money to make it $100. In fact, with the young man we did this for, the goal was within a certain amount of time not to have any limits because he was going to learn how to make good financial decisions. That's what a growth clause does. It lets us look. And if someone is declining, it lets us tighten things up. My mom, as she gets older, is not as good with money. So we've said spend up to this with no problem. More than that, she has a trustee, but it allows her to make as many decisions as possible. And it goes all the way through end of life planning. And I know it sounds weird to talk about death, but I can't recommend it enough. It's a chance to give people some power, some vision over the end of the road. And the end of the road is a scary place, but anyone who's part of a Medicaid plan knows that they're supposed to be discussing that with you. And I always thought it was icky too, until my dad was reaching the end of his path. And a guided conversation, which really is what supported decision-making is, that talked to my dad about his options of what he wanted as he reached the end. Do you want extraordinary measures? What kind of service, if any, do you want? What music do you want to be played? What things do you want to have done? Gave my dad a little bit of more power over something that none of us have power for. And that amount of supported decision-making made him happy. So it's worth looking at and something we should talk about. And that takes us all the way through life. We've talked about in 3 sessions why supported decision-making is important and why you should do it and how it can help. We have addressed everything from pre-K to end of life and ways supported decision-making can impact it. But I have to leave you with this. All of these things are great, and none of them will work if we don't start with the first commandment of supported decision-making we talked about way in our first session. We must recognize that everyone has the right to make choices to the maximum of their ability. And I know sometimes that means we're changing the way we've always done things. Sometimes it means we're taking a real turn, and someone will say, that's not the way we do things. We've always done things differently. Well, yes, of course, we're saying we're changing the way we've always done things. All of the things we've ever done as Americans and human beings that have been good, that have moved us forward, changed the way things have always been done. I'm sitting here in Virginia today. Well, in 1863, where I'm sitting, some people thought they had the right to own other people. That was the way things had always been done. We changed it and we're better for it. I told you when we began today, it took until 1990 to say that people with disabilities have equal rights. That means in 1989, it had always been that people with disabilities didn't have the right to be part of society. We changed that. So everything good that we do, everything that moves the needle forward changes the way things have always been done. And I know it can be hard to do that because it's easy to do what's always been done. It's easy not to empower people, especially when if we give people the right to make choices, they might make bad ones. It's going to happen. All of us make bad choices. If we say that you're not allowed to make choices unless you only make good ones, then all of us need guardians because it means we can never drink beer. We can never take a day off to lie in the sun. We can never do things that aren't completely illogical and in our best interest. And that's not the point of life. The point of life, as my favorite author says on your screen, is not to make things easy because it would be easy to do the things we've always done. The point of life is not ease. The purpose of life is to choose and act upon our choices. Yes, it can be hard to do that, but it requires 3 things to make it work: daring, effort, and resolve. We got to do things that have never been done before. We have to work harder than we ever have before. And we got to get up when we get knocked down, because you will be knocked down, because it's hard to empower people, but it's right. If I've taught you nothing in the last 3 sessions, it's that self-determination, making our own path, leads to a better life. So it is right. And if we do it, we reach the most important goal of all. We get to the point where everyone is the causal agent in their life. Everyone is getting the help making decisions that we all need. Everyone is giving and getting the help that we need to have our best lives. I always tell people this: if nothing I have done has convinced you that self-determination and supported decision-making are important, consider this as my final gift. If you believe in the things I say and the things I've shown you, and that there are opportunities around us, you can empower people to have their best possible lives. And if you don't believe in it, I hope you die suddenly. And that's not a joke. I hope you die suddenly, because unless you're lucky enough to die suddenly, do you know what you're going to be one day? You're going to be the one in the system. You're going to be old. You're going to be infirm, was the old word. You're going to need support. You're going to be in the system. And what kind of system do you want to be a part of? Do you want to be part of one that looks at you and respects you and empowers you and says, this is a human being with the right to make decisions? Or do you want to be in the kind of system we've always had, that sees that you have a limitation and decides it means you can't do anything? I think I know the answer. So the things we've talked about, they are right for the people in our lives. They are right for our children. They are right for the people we support, and they are right for us. And together, we can put supports and services into place that answers that first question I asked on the first session: what's your favorite right? Well, if we work and respect and protect people's opportunities to make choices, then all of our favorite rights will be equal rights. It has been my honor to be here. I am happy to answer any questions. I know we're up on time. I'll stay as long as you want. But if you have a question and can't think of it, that's my email address on your screen. Feel free to use it anytime. Ashley, I'm happy to answer any questions.
Thank you so much, Jonathan. A link to this session's evaluation has been dropped in the chat, as well as a link to our Padlet that has all of these wonderful resources, recordings, PowerPoints, and links that were mentioned during today's call. Before we sign off, I do have a few closing remarks. While this is the last session in our speaking series, we are excited to announce that the DNEA will be hosting a collaborative supported decision-making summit. Stay tuned for information on that in the coming months. And this summit will provide an interactive opportunity to learn more about supported decision-making and to hear from advocates who have pursued supported decision-making in Delaware. So it will be a wonderful opportunity to continue learning about supported decision-making. On behalf of the Center for Disability Studies and the DNEA, I just want to thank everyone who has joined on for this speaking series. And I would especially like to thank Jonathan for sharing his time and his expertise with us over these past 3 weeks.
Thank you all so much. It's been my honor to be here. And thank you to everyone who has hosted this. And thank you to everyone who is doing everything they can to empower the people in their lives. Have a great day.